Donato.
Newsmax is continuing to grow, and it's
Dr. Donato.
All right, time for the big reveal on the tomato.
Hey, welcome everyone, providers, to the first ever roundtable discussion. And we're going to be learning from each other, where no one has any advantage or disadvantage. We're all going to be joining in together. We will cover two subjects. It will be the screening test, the OncoDeclare, and then the CTC screening test, and that's the OncoTrace. So we'll cover those two for session one, and then on session two and session three, there will be other topics, the Onconomics Plus, which is a big thing. So it's my first time to moderate, facilitate this roundtable discussion, and please share your questions, and we hope that we can come up with good answers. But for now, we'll go over just the main details of what we're going to be talking about, kind of a quick review. And so I'm going to go ahead and share my screen. And if you have any questions, please interrupt. Not a problem. This is a group, like a small group discussion. And so we can learn more and hopefully come up with good clinical applications and outcomes. So I'm going to share the screen. And by the way, this meeting is recorded. So if you want to review, you can go ahead and contact admin who will provide you with this. Okay, so cancer screening. We're going to do a deep dive. So we, as you know, we have a new test that came out a few months ago, and that's the OncoDeclare test. And you can see that in the past, we've used OncoTrace for our screening, but it wasn't really a good screening test. It wasn't really meant for that. So we have the OncoDeclare now that is screening for early detection. That's very important, early detection, because it's earlier than an OncoTrace can detect. So if it's anything, you can come up with a 0 CTC. It doesn't mean there's no cancer. It's just below the level of detection. So we'll discuss that a little bit more in depth. So this liquid biopsy, this OncoDeclare test, is used for anyone with no history of cancer or with a family history of cancer, but not personal history of cancer. Okay? And so this is what you would get your patients to know about this testing, and you can order it for anyone. That's what's good about this. The OncoTrace test, on the other hand, can only be ordered, it should be ordered only for established cancer history. So if there's someone in remission, you would not want to order the OncoDeclare, it would be the OncoTrace test. If it is someone with already diagnosed with cancer, well, automatically it's an OncoTrace test, not OncoDeclare. Now, the methodologies are very different. They're vastly different in the sense that one detects, the OncoDeclare detects healthy cells to determine the presence of cancer, whereas the OncoTrace detects only the circulating tumor cells. So there's a big difference. And the circulating tumor cells, or CTCs, are a subpopulation of the peripheral blood mononuclear cells that the OncoDeclare will be screening for cancer. So that's why the OncoDeclare is going to detect earlier cancer than the OncoTrace. Okay, so the OncoDeclare methodology is isolating, what it is a qPCR test. It will isolate the messenger RNA and just a transcriptome test, which then they will do a reverse transcription to the complementary DNA, and then run it as a qPCR test to determine the gene expression profile. And from there onwards, that's where the artificial neural networks come in to help in this machine learning algorithm to produce an accurate result, which would be determining the presence of cancer, or if it's just a healthy sample. So it will help to classify cancer versus healthy samples with a very high accuracy. And you will see that next. The OncoTrace, on the other hand, is the methodology is vastly different because it is detecting circulating tumor cells with the isolation method, which is much more time-consuming, very a narrower scope. So what it really is a fluidic-based immunomagnetic isolation method with a multi-parameter antibody panel with flow cytometry. So it's a very much improved system in detecting circulating tumor cells. And these circulating tumor cells are not just any circulating tumor cells. We're looking at the cancer stem cells, because all the CTCs, to be enumerated, they have to have at least one of the cancer stem cell markers or biomarkers. And so you're actually looking at a CSC, and that's what matters because that's what drives the disease. It's the future metastasis. Okay, so as a review, you're detecting CTCs, and for OncoDeclare, you're looking at healthy, normal white blood cells to detect cancer. It's incredible. It's a game changer. Now, in terms of this, the accuracy at 93% average, you're looking at 92.4% true positive and a 94.78% true negative. So these are very high sensitivity and specificity that other competitors in the field of liquid biopsy will have a tough time competing, because this is such a game changer. We haven't seen a test with this magnitude of high accuracy, and we're very pleased with this included in our testing. Now, the OncoTrace, you already know that 86.2% sensitivity. It has a low false negative at 13.8%, but then again, that's something that you can help decrease if you have the proper blood draw guidelines, following the blood draw guidelines, and also making sure that you're getting enough blood in the discard tube to reduce the detection of the CD31, which is the endothelial cell contamination. So that will improve your accuracy if you follow the blood draw guidelines that we have now in your resource portal. So the OncoDeclare test has a algorithm here that is in your portal. And so when you have this test done, you have if you have a positive OncoDeclare, you only have a window to contact the lab to order a reflex OncoTrace, and it has to be within that window period. I think it's 2 days, 48 hours, right? It's 48 hours. And if you don't place the order for reflex OncoTrace, then you have to have a second blood draw. Okay, so if you have a positive OncoDeclare, as a conventional doc, you're gonna go ahead and order some diagnostic work like tumor markers, scans, scopes, and then possibly a biopsy if you can detect something, which would lead then to oncology consults. However, if you're an integrative practitioner, then you will just go straight also to ordering an oncotrace test because you want to see if there's anything you can do for this cancer. And so if you have a positive oncotrace, then you would just go through and order the Onconomics Plus, and that's how you can discover the biological treatment protocols. If the oncotrace is negative, that means it's below the level of detection of cancer, is much earlier, then you need to wait about 6 months. And in the meantime, you might want to start this person on a nutritional metabolic therapy to improve their health. And hopefully, when you repeat the oncodeclare, the cancer is no longer detected. But if it's still positive, that means this cancer may be resistant or it shows aggressive behavior. Then, of course, you may want to you will want to order another oncotrace, order another oncotrace test if it's a positive oncodeclare. After the 6 months, you repeat that oncodeclare. If it's positive, then of course you run through the same cycle of following this algorithm. So that's how you can use this algorithm for the oncodeclare. And if you have any questions at this point, it'd be a good time to answer. But this is what you follow. If the oncodeclare it becomes negative, again, when you order the follow-up, the nice thing about this is that means the cancer is no longer detected. So solve the problem before any further intensive care. Are there any questions?
Yes, I have a question, Dr. Donato.
Any comments? This is a
Yes, can you hear
wonderful
me?
screening test. Incredible. I've actually had somebody with a positive oncotrace and a negative Gallery test. That tells you something, that we're able to detect cancer much earlier than some other of those competitors in liquid biopsy.
And I do have a question.
Okay, so the important thing about the oncotrace test, now that we're going into this, is that the number is not enough to tell us what else to do. It just gives you the tumor burden, but you can't really tell the tumor burden, accuracy of the tumor burden much more accurately unless this person has never had any treatment. Then the CTC number, if it's a low number, then you know the tumor burden is low. Like if it's a 2 CTC per mil, that's a low tumor burden. But if it's someone that has undergone chemo treatments and so forth, and then you have a CTC of 2, that's not necessarily a low tumor burden, but the risk is still there because it's not below 2. So one of the things that you want to make sure is the goal is to get it below 2, and that will be statistically a much lower, clinically a significant lower risk for future disease progression. And then once you get below 1.4, then you're entering a territory of remission, which is commonly seen in people who are in remission for years. And when you see a very low number, that is typical. I mean, once in a while you'll see 0 CTCs, but your goal is to get it down as low as possible to as close to 1 or 0. Now the EpCAM number, which you see also reported, the EpCAM positive cells, these are a mix of both the EpCAM positive CTCs and also the EpCAM positive cells, normal cells. So that number is also important to monitor, and you want to make sure that number is going down and along with the CTC number. Because if If the CTC number is going down, but the EpCAM positive number is remaining the same, then that tells you that it's very likely that the majority of the CTCs that drive the disease are still in that group. It hasn't really improved very significantly. That means the ones that have fallen down are the ones that are not as aggressive. So it's very important to also monitor the EpCAM positive number. It needs to go along together with the CTC going down towards 0. And it's a subpopulation. It's a lower number than a CTC in general, although sometimes the other healthy cells can make that higher than the CTC. Now, the cancer types that can be identified among the cancer types are the hematological, the lung, neuroendocrine, melanoma, sarcoma, breast, prostate, and renal. But that doesn't mean it can't detect anything else outside of that group. It will detect all cancer types except the CNS type, because you're not going to be running that since we don't detect the primary brain cancer due to the blood-brain barrier. And so you're just going to focus on the non-CNS cancers. And so these are the ones that are commonly seen and be able to determine the source. But if it's not one of this group, it still is going to detect all the cancer types out there, but it's not going to have a label. So in that case, then you need to do a further identification by ordering, such as the ACGH test as an example. But again, it will detect all cancer types and except the CNS type. So what's important about the OncoTrace is not just the number. Remember, you have to look at the stemness and metastatic biomarkers, because that tells you the risk or the prognosis. How can you tell a prognosis by just looking at a CTC number? Let's say you have a CTC of 3.5, and then you look at if you don't know about the stemness and metastatic biomarkers, that 3.5 may be good or may be bad. You don't really know the risks. So to check the risk, you have to look at the stemness markers. That's the CD133, CD44, NANOG, OKT4, SOX2. So all of those will give you the risk level, the risk for resistance, recurrence, and their aggressiveness, particularly the OKT4 and SOX2. So those are the two that you want to really hone down and look at, because those are the two that are the last to die. These cells are going to hang on to the very end. And so if there's a decrease in the percentages or a downgrade toward the negative, you know that there's a significant improvement in the patient's health status. The metastatic biomarker, we're looking at the CMET. CMET must always be 0. If it is dim or positive, this is a high metastatic risk. So that could change your treatment approach if you have a high metastatic risk and a high resistance and recurrence risk. So that's why it's important to have the OncoTrace, especially at the beginning. That's why you order this as a baseline test for all cancer types, whether or not you know, or whether or not this cancer is established, the person has an established cancer type or not. Just order the OncoTrace in case there's more than one type of cancer. So the clinical decision making then boils down to, if this person has a positive CTC with high risk, you certainly want to encourage or discuss with the patient that there's a recommendation for treatment, and that you can order the Onconomics Plus to determine the specific type of therapeutic regimen that will be effective to the patient's cancer without the guesswork. And that's the advantage that we have over any other lab testing or molecular oncology testing out there, is that we have this chemosensitivity testing that will give us what is most effective for this patient's cancer. And that, of course, will translate to improved outcomes. Short-term goal, if you remember, is that you need to reduce the CTC as quick as possible to less than 2 cells per mil. And then long-term goal, you want to get it down to less than 1.4 or as close to 1.2 or 0. And that's essentially when it's no longer detected. So that's very important, because anytime you have a count of CTC number that is not below 2, there's still risk where it can be very different from a scan. It may be just diametrically opposed, where a scan shows all kinds of masses showing up in a stage 4, and yet the count is down to 2.1 from 5. And you would think there's a huge change there, and yet the scan shows otherwise. So in order for you to really see that matching up with the patient's improvement, you need to get it down below 2. And that's where statistically things will start to match up with the scans. Otherwise, you will easily be thrown off. Even though cancer cells are dying, you're not getting rid of the dominant cells driving the disease, which are the ones, especially with the OKT4 and SOX2 markers. Okay. Here is an example of a case that is stage 2 high-grade right breast cancer, invasive ductal carcinoma, and triple negative. Okay, so you can see here that this person has very advanced cancer that has a Ki-6 to 7 of 30 to 40%. That's not a good situation for this patient. And so the recommendation is to do neoadjuvant docetaxel, carboplatin, trastuzumab, and pertuzumab, followed by surgery, radiation, and adjuvant systemic therapy. That's a lot of very conventional approach, and this patient is afraid. She doesn't want to go through all that. And so she declined the recommendation, and instead she pursued cryoablation, and then agreed with the trastuzumab and pertuzumab months later. Now, this is interesting. Why take this trastuzumab and pertuzumab when this is a triple negative breast cancer, which is kind of interesting. And that's because the tissue biopsy showed that she has HER2 positive, whereas the Onconomics Plus showed the HER2 negative, and that's the CERB-B2. And so it doesn't always match with a tissue biopsy, but again, they recommended that drug for 11 months. In the meantime, you can see that I did a baseline check on her, and this was at 3.8, and the subpopulation EpCAM positive cells were at 3.2. So this was done prior to the treatment, and then it has gone down over time to 1.6. And remember now, if it's less than 2, that would be clinically very significant, because there's a lot less risk for future disease progression. Now look at this change in the biomarkers. You got to watch that carefully, because you see, if I didn't do a follow-up, I couldn't tell when something would change. The CD44 was dim or trace, and now it becomes positive 50%. So it actually increased in their numbers in this particular stem cell marker in the population, and it remains the same the whole time. So there's been a change there. However, even with a drop from a 3.8 to 3, you can see that even then there's not much improvement on the stem cell markers. As far as the OKT4 and SOX2, when you can see both of them present in the baseline, you know this is going to be a hard case. It's not going to be an easy case. If one of them is negative, then you'll say, okay, this is not too bad at all. It should work out well. It should not be a difficult case. That's how you can tell if you have a hard case or an easy case to work with. And you can see they're all the way down, even at 1.6, the OKT4 SOX2 are still there. They're the last to die. They practically have to get down to around 1.2 or so before one of them becomes negative. Once in a while, you can see that they will flip. One becomes dim and the other one becomes positive, but they're not going to be negative until they're very low in the numbers because they're the last to die. So in my interpretation here, at the second, when they did a follow-up, when you see a change, I would say there's a response to therapy because it dropped from 3.8 to 3, but with caution due to increased CD44. So you got to watch this because there's a little bit of an aggressive behavior increased from the baseline. Now, this is another case that shows from a papillary thyroid cancer. This patient didn't want anything done other than having gone through hemithyroidectomy. And so she had a measured of 4.8 centimeters confined to the thyroid gland. And so the Ki-67 at 3 to 4%, margins uninvolved, and there was one lymph node involvement. So when I did the baseline, it was 2.4. And when you look at the risk, you look at the stem cell markers down to OKT4 and SOX2, only one of them showed positive and the other negative. So obviously, this is going to be not a difficult case to manage. And that's all she did, is just doing the RGCC recommended protocol and a change in her lifestyle and dietary modifications. And so you can see that the CTC went down fairly quick. And once it has reached the 1, it kind of stayed around there. And so you could even go as far as 1.4 and still nothing detected by imaging. And even though there's been a change in the markers here, so the OKT4, which is ranked at a higher level with the SOX2 than say NANOG, CD44, and CD133, yes, the OKT4 went down to dim from positive, and that's in the 1 range here. Now, of course, I did OncoCount, and you can't see what's happening in the OncoCount test. That I stopped ordering it. I'm only ordering OncoTrace or OncoTrail because that gives me a lot more information and when it actually happened that the OKT4 became dim. So that's a significant change for the better. Even though the NANOG went from dim positive to positive, the OKT4 change is much more significant. The OSOC still remained negative. And you can see here that there was a change in the EpChem markers from 100% down to a 75%. What you want to see here is you want to see it remain the same or higher. Well, if it was 50%, then you want to see it 75 or higher. But here, you wanted to see the same at 100%. So there's been a change in the behavior here where it's downgrading to a 75%, but it's still considered well differentiated. And at 1.4, the risk is very low for any future disease progression. Of course, the scans, ultrasound showed negative. They can't find anything or no evidence of disease. And so generally in a safe situation like this, we'll just do a maintenance follow-up of every 6 months to once a year for the first few years. Okay, so this was successful in the case management. And so our future roundtable discussion will be the economics plus, and we will talk about that in 2 separate sessions. These will cover gene expression and the chemosensitivity. Do you guys have any questions?
Miven, can you hear me?
I'm open to that.
Miven, can you hear me?
Dr. Baum, I don't hear you if you're saying something.
There's questions, but no, you can't hear anybody.
Let's see, am I?
I have a question.
I have to check my audio to make sure. Not if you can hear me. Did I sound
You're fine.
okay? All
But
right.
you're talking.
But
Can
why
you hear
am I
us?
not hearing you? That is so strange. Let me see my audio setting here. Maybe it's I'll change my speaker to, okay.
Can you hear us now?
Now I can hear you. I have to remove my AirPods.
Okay, Dr. Donato, you look in the chat. You have several, because you couldn't hear people. They put their questions in chat. If you would be kind enough to answer those questions.
Okay, let me see the comments here. Chat. Okay, so here's a question. Is there an option to automatically select reflex if onco declares positive? Yes. So you have 48 hours from the time it's reported into your portal. So you got to watch the notification. Then you can do an order reflex onco trace. So you have 48 hours. Otherwise, you have to submit another sample. Okay, so that answers that question. Another one is, let's see. Okay, what does oncodeclarer look like if it's not used for early detection? I realize this would be incorrect use of it, but would like to understand. So what does it look like if it's not used for early detection? Okay. If it's an established cancer, you're always going to show a positive oncodeclarer. So you're wasting the cost of it. You're going to have a positive oncodeclarer for any positive cancer. So that's why you don't use that for already an established cancer. Right? If that is the way I should be answering that question. What if someone is atypical cervical cells? Would you order an oncodeclarer? I would say that yes, I would order the oncodeclarer because it is a screening test. It's one of those things where you want to know for sure if cancer is developing. That's why that screening test is there. Because if it is, then you want to know if there's any, if you need to address it as a provider by doing additional testing, which is the oncotrace. Okay, let's see what other questions is there. Okay, a few of my patients only wanted to order an onconomics without an initial oncotrace or oncotrail because the onconomics provides the CTC count and they want to save some money. Do you recommend an initial oncotrace or oncotrail anyway? Okay,
Yeah.
so you can order the onconomics because what's going to happen is when you do a follow-up in 3.5 to 4 months, you're going to have to order an oncotrail or oncotrace anyway. And so you'll just be 3.5 to 4 months behind in discovering the risks and the prognosis. So yes, it's okay to do that and just find out later what the stemness and metastatic risks are in the follow-up. I hope that answers your question. I kind of like to have all at once in front of me so that I can compare it to a follow-ups because sometimes you'll see the stemness markers change even before they get down to the lower number. Oh, rarely. I've seen it happen at least once, and it shocked me because I thought, wow, we're having such a good change in the biomarkers so soon. So you will miss that then. I have difficulty to understand how can advanced stage like 3C or 4 with detectable mass patients can have low CTC and others with no tumor detectable by PET scan, for example, have higher CTC counts. Okay. You have to understand that it's not, they all have their place in terms of accuracy in the information. So the scans are accurate, and then the liquid biopsies are accurate. But you have to learn how to to integrate those information, one thing we know for sure is what you see is not necessarily what you think. You have to think again, or Dr. Ioannis would say, think again, okay? Because what you see as a mass does not necessarily mean that it's exactly a quantifiable cancer cells, because you really don't know what's in that mass, because there's part of it that's malignant and the other part are stroma. You can't tell. And sometimes the stroma will increase more, and sometimes the malignant mass will increase more. You can't tell the difference. They're just looking at a mass, and then of course in a PET CT, you'll see some activity, increased SUV, but that doesn't necessarily mean also that that's an activity of cancer, because if cells are inflamed, they're going to have an increased SUV. That's why you don't want to have any scans done on someone with significant inflammation or fever, things like that. It's going to mess that up on the SUVs and the FDG values. It's just not going to be accurate enough for the radiologist to tell the difference. So it's really not the same as counting cancer cells. However, my suspicion is that if the CTC is going down, but then there's a lot of masses, that simply means to me that I have to be careful and not assuming that those masses are all cancer. Okay, they may just be reactive due to the immune response. And so what's curious here, someone said to me in the past, well, I had chemo and all those masses disappeared. Well, you know why those masses disappeared? Because it killed all the white blood cells too. So that obviously, if white blood cells are destroyed, it's going to shrink the mass quick as well. So it's not all like a black and white. There's a lot of gray area when you look at a scan. And when you look at a CTC number decreasing, that's the output of whatever activities in the tissue. So if the output is increasing, then we know that there's an increased activity in the tissue. So that's how you can tell. But you're not going to be seeing anything matching up until you're less than 2. So if you're less than 2 CTCs, they start to match with scans. Anything above 2, don't bet on it. There can be changes in mass sizes large, and new masses are appearing here and there. And then you look at the CTC number, oh, it's above 2, no wonder. But if you get below 2, statistically, they start matching up, especially as you go down to the 1.4 and lower. You're going to see that more congruent, more correlating to a no evidence of disease. I hope that answers the question. Anything else?
I have a question, Dr. Donato.
Yes, go ahead.
Okay, on the Onco Declare, I've done those. And quick question. So when it comes back and it says, this is classified as cancer, is that not diagnosing? Isn't that going to, I think it's going to scare a person? And then secondly, so I'll let you answer that. But the other part of the question is, so it comes back as cancer. We do an oncotrace. The oncotrace is 0. But then we did an Onconomics Plus with new blood, and it came back with cells. So I'm having a hard time wrapping my head around that.
Okay. Here's the possibility. You know that there is a 13.8% false negative in the trace. You know that, right? So,
Yes.
And why is that? It's because of 2 major things. The blood draw technique. If you do the discard tube and fill it only half of it instead of full, there's still a chance that the endothelial cell contamination will go into the patient's vial. So that's why you fill out the discard tube completely. That's one possibility. And the other is that you didn't follow the window of time when it's the right time to draw the blood. Because if there's any systemic treatment happening, you're going to have a lower number. And then when you start following the guidelines and then you get the blood draw, because you follow the guidelines, then the number shows up. So that's why it's very important to have the proper timing of the blood draw to get the most accurate results.
So we did the blood draw for the Onco Declare. It came back, we immediately went on to the OncoTrace, came back 0 cells, but it had CD,
P1
whatever.
positive.
Yeah,
Right.
yeah, the two positive yeah. And then did new blood for an Onconomics Plus or Onconomics Extracts Plus, and it came back with 1.4 cells.
Okay, so you have a more accurate results in the Onconomics Plus because the OncoTrace was contaminated. Unfortunately, the Onconomics Plus doesn't have the CD31 to determine if it was still there or not. So the first blood draw, obviously, I mean, the OncoTrace was not a good sample. It was contaminated, and that's why it showed a 0 CTC. The CTC is hiding behind endothelial cells.
And so what my question about the being diagnosis, because it'll scare a person half to death. It says this is classified as cancer. So when I tell somebody that, it's kind of a little bit scary. So just that was my question.
Yeah, so there's no difference with that than going to a doctor's office and they'll still find out they have cancer down the road. So it's just early detection. That's all it is. We just assure the patient that this is a preliminary. We don't know if there's a lot or this is very early. We have to run some tests to see if it's something that we have to be really concerned about. And so that's why we need to order the OncoTrace test, because this is part of the workup process. So don't be all too excited about it. There is cancer presence, but there are times when the cancer presence is very low in the level, very early. We may catch it early. This is a good thing that we found something, because we could have caught this early and hopefully prevent anything progressing from here on.
Yeah, that makes perfect sense. Yeah. Yeah, that's what I thought. It's just the fact that on all of the other tests, when we send in, say, an OncoTrace and we do an Onconomics Plus, I usually have pathology reports from the patient. So I already know what the stage is. I'm not making anything up myself. I'm not making any kind of guess or determination. I'm not diagnosing. I'm giving them that information. So that's why about the OncoDeclare, I have explained that to people as well, that, this is just early detection. Be grateful that we have a test that, you can be proactive.
Correct. And of course,
Proactive.
follow the algorithm as a conventional doctor. You may want to go ahead and order some additional workup like scans to get markers, tumor markers, routine tests, and see if something can be detected by conventional workup. But in the meantime, you'll be ordering the OncoTrace, because if it's below the detection level for diagnostics, clinical diagnostics, then at least from the RGCC detection, we can see we caught them early, and it may be resolved before it becomes more advanced. So this is a good thing, because it's going to prevent any more future progression.
Thank you so much.
Okay, another question came out as, if CTC is 0 for a positive cancer patient, do you suggest proceeding to the Onconomics Plus? Okay, so I know why you're doing that, because you're trying to see if to save money from repeating the OncoTrace or OncoTrail again. Actually, OncoTrace in this case, because you're doing a screen for CTC. So here's the situation. You should not order an Onconomics Plus if you don't know the cancer type. It's preferred not to, because knowing the cancer type, when you order, the Onconomics Plus, you have to enter the cancer type and the stage, right? So by having the cancer type, then the lab will be culturing them in a culture-specific or cancer type specific media. So if it's a breast cancer, they're going to use a breast cancer media to culture the cells. And so that's why it's important to have a cancer type. Now, if you already know the cancer type and it's a negative OncoTrace, and you want to repeat it down the road, yes, you can order the Onconomics Plus because you already know the cancer type. This patient has an established cancer, and hopefully the Onconomics Plus blood draw was perfect and there's no contaminant, and it will show the positive CTCs. And that's when we can then determine what biological treatment protocols can be determined. So I hope I answered that question correctly. Anything else? So far, this is good. This is a good discussion, but all of you are practicing. I'm basically speaking to the choir, as it were. So please make some comments. What do you think? Are we in the right track? Is there something here that we can learn from?
I think all the information we can get is always beneficial. You can never, you need to continue learning every single day. And every time we talk, every time I talk to you, I talk to Dr. Bime, I learn something new there. I pick up on something that I didn't know before, or maybe I've heard it before. It didn't resonate with me like it should. And I pick up on different things every time we speak. So I think this is really, really good.
Right. I'm a provider myself. I work only part-time with RGCC in the clinical support. So I have my own cases. I'm in fact actually one of the busiest in ordering testing. I've ordered over 1,000 tests in the last 4 years. And so on top of that, I've assisted many doctors as part of the RGCC clinical team. So so this is very routine to me. Your confidence level will go really high the more tests you order. So don't be shy. Order tests according to the guidelines, and you're going to get more and more experience with confidence. And we are here to support you. It doesn't cost you at all. Just schedule yourself in clinical support, and we'll assist you in your workup if there's anything you need to get consistently good outcomes, because my outcomes are very consistently good because I follow the rules. There's some fine lines behind that you will eventually will probably share down the road, but my cases, as you can see, a lot of my cases are getting the CTCs down into the low 1 range. Now, how many of you have brought your CTCs down below 2 consistently? You see, that tells you something about what you're doing, but you can improve on it, and we'll share that down the road. But right now, the main thing is the focus is how to manage and how to work through this testing, these 2 tests, the very most important entry into the RGCC system. Now, there's a question here. If the CTC is 0, how long would I wait to order the Onconomics Plus? Okay. So this person must have a risk for you to consider ordering the Onconomics Plus. So I would say that probably 3 months, because if there's any urgency, you may want to order sooner, but at least 3 months. I mean, you realize that in 3 months, the disease could be progressing along. And if you notice that in your examinations, and the patient comes back in a month or a few weeks, if there's an urgency, you can go ahead and order the Onconomics Plus. But typically, I would wait at least 3 months before ordering an Onconomics Plus if CTC is 0. And usually, if CTC is 0, you're gonna if there's cancer, you're going to be very suspicious because CD31 is dim or positive, and pan-CK may also be positive. So that's why you look at that result, not just look at CTC 0, look at the biomarkers. If CD31 is positive, then and you have very suspicious that there's cancer, you might discuss with the patient that there's a possibility that the count is quite low and it's not able to detect it due to this contaminant present, which is that endothelial cell, and we should go ahead and run the Onconomics Plus. And of course, if you have a 0 count on the Onconomics Plus, there's no viability assays done. Obviously, then it'll be downgraded to an Oncotrace or Oncotrail, and then you'll be refunded the difference. So yeah, you could do that. I hope that answers your question. Do you have a suggestion for tracking the results or pathways? Okay, so so you need to have a spreadsheet that, like I showed you in the slides, and that's how it can tell whether cancer has developed resistance over time, because you're not going to see a nice linear decrease in the CPCs. After 6 months, they usually start to stabilize, and that's why the secondary resistance developing is a problem, and you may need to repeat the onconomics testing sooner than 1 year. They recommend 9 to 12 months, but sometimes I've repeated it in 6 months. It just depends if the MDR1 is really high. A high MDR1 would probably tell me I might have to repeat the onconomics in 6 months.
Right.
Okay, so what kind of dietary, nutritional, or remedy recommendations do you give when the oncodeclare is positive, but the oncotrace is negative? Okay, now this is where it depends on your background as a functional medicine physician or provider, because a lot of this this cancer management, it's not just about using targeted approach to destroy cancer cells. It's about environmental change. If you know, if you recall in your study about cancer, is that the tumor microenvironment is what supports the cancer, and it supports the gene expression
Right.
to abnormal. So you have to change that environment. And as a functional medicine doctor, one of the biggest thing that you want to make sure to involve in the therapy is a dietary change and putting them on a low carb diet. You know, many doctors prefer the ketogenic diet. I prefer a plant-based low carb, but again, your background is already telling you where to go on a low carb, and also at the same time, a high oxygen environment. As you know, the hypoxia is what triggers a lot of these cancer over time, and so chronic hypoxia. So these are involved in the nutritional metabolic therapy. Again, it's a metabolic because that's exactly what you're trying to address to correct this disease, is improve their metabolism, improve the environment of high oxygen. And after 6 months of that, then you retest. And if it's negative, the cancer is gone. That's simple. There's no more cancer detected. It's really a good test to see if your therapy was effective in addressing a positive oncodeclare. And if it's negative, the patient will be ecstatic because their cancer is no longer detected. Okay, another question here. If oncodeclare is positive, would you consider running a Gallery test, which might tell you the tissue of origin? Okay, so a positive oncodeclare test means there's cancer, and so what you could do if you want to determine the cancer type, yes, you can order the Gallery, but in the RGCC, you know that you can order the OncoTrace and the ACGH test to help you determine the source of the cancer. But if you want to use Gallery, then it can tell you up to a certain number of cancer types. I think like 20 or so types that they can point to, but anything beyond that, I guess it's not going to detect it. But yes, they detect all kinds of cancer, up to 50 types. In fact, I believe 50 some, but only 20 some is named. But the other ones are not determined. It's just that, you know, they can detect all kinds of cancers, just like us. It's just that we are more limited in terms of the antigen that we use in our antibody panel. So yes, it's possible you can order the Gallery. The Gallery will tell you the cancer type, but how does the tissue of origin? Why do you want to know the tissue of origin if you have the chemosensitivity test to tell you what to use? Why would you want to know the tissue of origin if you cannot discover that? Because if you enter cancer of unknown primary, they will still culture it, and you will know if CTCs were present, of course, and then you will know what agents to use against the cancer, how will the tissue of origin change that mode of treatment? You see what I'm saying? I think the only reason why in the conventional arena, the reason why you have to have the tissue of origin is because the FDA has already approved certain drugs for a certain type of cancer at a certain stage. So you're looking at a different paradigm, a different system. And in this case, you have everything you need, whether or not you know the origin. You have everything you need. And I've seen that happen many times for me, and I don't have to know the origin unless, of course, like I said earlier, that you can have a better culturing for better, more viability testing to grow these cancer cells. Yes, it's good to have the better medium, but really the bottom line is it really going to help you to know the origin in terms of treatment? Is it really going to help you when you already have it in the Economics Plus? Any questions there? Okay, we have 4 minutes. And if there's any other questions, this is the time to do it. I hope that I have given you a satisfactory answer. I think that's just me. I've been running this test for 4 years all the time. I'm one of the busiest providers, but you may have good answers, and we need to share and learn from each other.
I know that one of the questions asked is about they wanted to run an Onconomics without an OncoTrace or an OncoTrail. I've just gotten to the point, if the people want to argue with me, I just, they're not a good fit. I'm doing what I feel is best for you, and yes, you're wasting your money if you're only going to do part of it. If you're not going to follow through with the follow-up testing, you're really wasting your money. And sometimes I just talk people out of becoming a client. It's just because it's not going to be worth it. It's more aggravating to me. And I've really, Dr. Baum kind of told me this a long time ago, be a little more selective and, because you're in charge. Because I had someone call me who wanted to do an SOT. And I told him I wouldn't do a consult without records. I got the records. And during the consult, he made the comment that he had a PET CT. And I said, well, it's not in your records. Where is it? And it showed he had mets to the lung. And I told him, I will not do an SOT on you right now because of the size. And he got mad, never came back, and called around, and he's trying to find another RGCC provider that will give him an SOT. I'm not going to do it. He's not going to convince me to do something that I don't feel is correct. So I just feel like I got a lot of really good advice from Dr. Baum. And the thing is, we're the ones who have done all the training. And if they don't want to take our advice, then they don't really need to come. I mean, we're trying to do what's best for them and give them the best results. And like the 14 days, I'm having people buck me on the 14 days, not taking their supplements 14 days before a blood draw. And I've just told them now, these are the rules. We're going to stick to the rules. You're going to get the best bang for your buck on your test because they're going to have the most accurate results. And if they don't like that answer, then they don't necessarily need to come.
What's interesting is I have never, maybe I've had maybe less than a handful out of 1,000 orders that someone actually said to me that cost too much because they were wanting personalized therapy. So if I needed the test done, I need both OncoTrace and Onconomics Plus, $3,100. They just said, go ahead, use my credit card. And so it's not an issue. I think it's how you communicate with the patient. If they're actually turning you down and say, that's too much. I'm willing to pay for the Onconomics, but I don't want to do the OncoTrace. That sounds strange to me, at least, because somehow it didn't get across to that patient the importance of having both as your baseline. I don't understand that.
Having stem cells of everything.
Challenge, I may on my own order the Onconomics Plus, not because they told me to, but it's because of my decision. But most of the time, I said 99% of the time, I'm ordering both because I want to see my baseline and follow it correctly. And if you follow correctly and be consistent, you're going to get very good results. And that's why my results are very good. I have no problems managing the most difficult cases because I follow the rules and I have the confidence of the RGCC data.
I do the test. I just tell them you have to do it. That's how we do it. You're right.
Right.
We follow the guidelines, what the lab suggests. They've done this for many years, and there's a reason that they've been successful is following these guidelines.
One wrong move and you get reviewed by the board, it could be history for you. So you don't want to mess up and you know, being a licensed provider. So don't take risks. You know, what you have to realize is that these tests are very powerful and the therapies are very powerful. But if you don't follow the guidelines and you get into trouble, it's really hard, you know, if you're the person. And so I haven't made any mistakes yet, and I don't plan to. But you know, like I said, I've done over 1,000 tests in a few years, and it's been great. I've been very satisfied. All my patients are satisfied. They're getting care, whether it's with concurrent oncology or without oncology. It didn't matter. The main thing is that they've got the results they were looking for, with only a few being very advanced and no way to stop on time. And that's the way it is. But again, it's patient's choice. And you just have to be clear with them that these tests are liquid biopsy. They're very, very latest in technology, and the conventional circles don't have this integrated in your system yet, because you know it's quite advanced beyond their training. So yes, we'll do the conventional diagnostic workup along with this information to give you a more accurate status of the patient's cancer. So we always integrate it. It's not a replacement to the conventional diagnostic workup. We still have to have that. They have it. They have to have it anyway to enter the system of conventional oncology. But for us, we've got what it takes, and it's all encompassing within RGCC workup and therapy. Okay, well, this is recorded, and so you can get a copy of this. I recorded it into cloud, and so the administration will be able to send you a copy if you would like that. And so our next round table will be Friday, July 19th at 11 a.m. Central Time. You might get a reminder announcement somewhere, but you can mark it on your calendar. Friday, July 19th, 11 a.m. Central Time. We're going to be discussing the onconomics plus, the extracts plus, and we're going to cover the chemosensitivity and natural substance sensitivity. That's our focus. And then on for session or part 2 will be on Friday, August 2. We'll be discussing the onconomics plus and the extracts plus gene expression profile. How do you use that gene expression profile? Remember now that the most important to you, that is removing the guesswork specifically, is the chemosensitivity. The gene expression profile is an advanced application to the chemosensitivity to increase your customization of the therapy and to discover what likely gene pathway is most likely influencing the disease progression, and that you can focus more on that area. So it's really a very comprehensive information. That's why you can't replace the Onconomics Plus, and you should order Onconomics Plus, but we'll discuss that more. That's going to be your tool bag. Okay, well, thank you very much for this attending the roundtable. I hope this was beneficial for you, and in the future, please be participative, because this is for you. This is not, of course, for our branch. This is just for everyone that are members of the North America team, and you guys are our legs, as it were. You're out there, and I'm also part of the provider group, so I know what you're going through. I know what you're going through. And so, is there any lasting words, my supervisor, Dr. Vine? Is there anything else you would like for me to mention? I missed something?
Nope, you did an awesome job. I hope everyone got a lot out of it. And I think we're all looking forward to your Onconomics Plus deep dive, because the tumor genes and using all that information is obviously one of the hardest parts. So I hope everyone will come back and join him for that. And we look forward to seeing every one
Now
of
I'll
you.
show you more case reports so you can see more of these spreadsheets, so you can see how this cancer has improved over time. So you guys have a good weekend. God bless, and bye-bye for now.
Bye,
Thank
everybody.
you. Bye-bye.